cardiovascular disease.
The cardiovascular disease. All right. So, as I wait for it to load, now that you kind of understand what you're looking at in an EKG, now we're going to move on to management a little bit more, as well as some of the pathophysiology of regular old diseases that you're probably going to end up seeing. A lot of the times, patients are fairly well managed with a chronic disease, but sometimes things kind of go sideways, right? They maybe miss a dose of their medication, or holidays. Holidays are a big thing. You see a lot of cardiovascular disease issues around the holidays because people go, they eat a lot of food. This food happens to be particularly salty, and it screws up their blood pressure. So right around the holidays, you'll see APE galore. Like you'll just like make sure you have a CPAP with you at all times because you're probably going to be putting it on people. They've actually done a study that people are, I think, 40% more likely to die in those like 2 weeks from like Christmas to New Year's Eve. Like those 2 weeks, it's like a very high morbidity mortality rate. Just because it's like, it's stressful, right? You have to spend time with your family, extended family, who you might not like that much. And you're eating food and you're drinking alcohol and you're like, it's just a lot, and your body just gives up, especially if you're dealing with like kind of like either chronically managed diseases, or you don't know you have a disease and your body's like, nope, it's too much. Poof, right over. I don't know if anyone saw this guy.
Hey, the heart rhythm guy.
Heart Rhythm Guy. Highly recommend watching Heart Rhythm Guy. He's just fun. Anyway, so assessment of the cardiac patient. So you can't tell me that you've never walked on scene and you've had a patient go, oh, what's your past medical history? I don't have any history. Okay, what medications you take? And they hand you a big old box of medications. And now it's kind of your job to figure out what their medical history is. You will get very good at this, okay? And this is I highly recommend learning about different medications and what they're used for, as well as some of their off-label uses, or if they're used in combination with a different medication to treat a specific disease, because you will become like the best medic detective to find out what's going on with the patient who just hands you a box of medications. So traditional ones that we see, right, is your nitro, any antihypertensives that might pop up, right? You got your beta blockers, your calcium channel blockers, your ACE inhibitors, your ARBs, which are fairly popular these days, right? You have all of those different options. Statins, right? Statins generally mean that a patient has a history of high cholesterol. Unless you're in Queens, which this one is always my favorite, where you'll have the Guyanese patient who will tell you that they take aspirin for their cholesterol. And without a doubt, they actually do have high cholesterol. It's just like a horrible genetic issue that they deal with. But they never take their statins for some reason. I don't know why. It seems to be like one of the cultural issues that they go to the doctor. The doctor's like, oh, just take an aspirin. Anyway, I digress. Digoxin is, for people who have a very weak heart, that digoxin helps kind of boost the contractility. Not super popular. You don't see that one as much anymore because it does have a very narrow therapeutic index, so people can get really sick with the digoxin. Lasix, right? Super popular. I don't know if anybody knows Mike Albert. Mike Albert the brunette. There's two Mike Alberts in the city. There's Mike Albert the brunette and Mike Albert the blonde. Both are medics. I think the blonde is no longer a medic. I don't know. There was some drama I heard about him a while back. Go ahead.
Sorry for interrupting. Are you recording right now?
Yes, I am. So he was telling me that they got called to a private house for a patient who was having a difficult time breathing. There was a nurse on scene, and the nurse was saying that, oh, I'm a hydration nurse. That new thing where everyone goes and they go to like the IV bars and they get hydration. So this guy's there foaming at the mouth, water's like coming out his ears, um, and he's like, "Is this, did you check his history?" And they're like, he's like, "Yeah, he's fine." They're like, does he have CHF?" And the visiting nurse goes, "What's CHF?" And after he controlled himself so he didn't smack the guy, he's looking at the patient's medication. The patient's on Lasix. He's like, "How much fluid did you give him?" And he goes, "Oh, 3 liters." So this guy, this hydration nurse, dumped 3 liters of
Funny.
fluid into a CHF patient and was unsure as to why he was bubbling like a goldfish. So you keep that in mind, right? And then you have patients who, they have their Lasix, they take it, they don't take it. Again, back to that holiday thing, right? They're drinking a little bit more than they should. That alcohol is still fluid. That'll potentially overload them as well. A lot of different things, right? Your diabetic meds, right? Check the fridge if you are uncertain about an AMS patient, because insulin is commonly kept in the refrigerator. Any erectile dysfunction medications, right? Because that can do some pretty wild things to a diseased heart, okay? Men who take erectile dysfunction and have an underlying cardiac issue can potentially overexert themselves in the bedroom. So things that might cause, various cardiac issues. Illicit drug use, cocaine in particular. Cocaine causes little microemboli, and those little microemboli cause heart damage and chest pain, and actually can cause a fairly significant MI. So if you have a patient who you suspect might be using drugs, that's a great it's a great question to ask. Patients who you're probably going to have a cardiac issue, right? Are those who have those various comorbidities, right? They maybe had a previous heart attack. They've got a number of stents, a CABG, a coronary artery bypass graft, right? Once they start collecting more than like 1 or 2, you're like, okay, you're kind of scary, right? They're like, "I'll have CABG times 5," and you're like, "Too many, enough. That's quit. Eat a vegetable." Patients, and this is just like on the side ones, patients complaining of indigestion that does not get better with antacids have a high suspicion, okay? Could be just GERD, could be that they're having, a non-traditional chest pain. Other various accessories that patients might have, right? The VAD, we talked about the VAD a little bit last week. ICDs, okay? Internal cardiac defibrillator, a PPM, permanent pacemaker, okay? Usually the ICD and pacemaker are kind of coupled now because they're assuming that if you have one, you're probably going to need the other. It's easy enough for them to turn it on rather than go back in and do surgery for a complete new device, okay? It's just a lot easier for the doctor and the patient. A lot of different chief complaints do exist, okay? We talked about this a little bit, and we're going to talk about it a little bit later as well. But just because a patient does not have chest pain does not necessarily mean that they're not having a cardiac event, okay? Syncope is, you should have a very high level of suspicion, okay? People can just pass out, but if they're having a dysrhythmia of some sort that's causing them to pass out, right? It's like a chicken or the egg kind of thing. Shortness of breath, especially upon exertion, right? Patients have a hard time exerting themselves. Often it's because their heart can't keep up. Usually their lungs are fine, but their heart is having a hard time keeping up. My mother was having issues a few years ago, trying to just walk around the block, right? And she went to the doctor. Doctor's like, "Oh, you're fine. Just you have to lose weight," right? Women, ladies, if a doctor ever tells you all you have to do is just lose some weight, go see another doctor. And so she's trying her best. She's out there. She's going for runs and stuff, and I'm running with her, and she's just, like kind of gray color, just not a good color. And I was like, "Hey, I think we need to go to a cardiologist." She goes, "No, I'm fine. He told me I just need to lose weight." I'm like, "Yeah, I'm gonna make an appointment for a cardiologist." 4 stents later, she was running around the block like on the edge of having a massive MI. So, not everybody presents the way you 100% expect. So just make sure that you're very thorough, okay? It does not hurt to be thorough. Just because, you might have a preceptor who's like, well, why are you doing that? You're like, because I want to be thorough, or, oh, just because I'm the medic student, right? It's better to do a test like a 12 lead and know for sure that the patient's okay than not do it, get to the ER and look like the fool when you missed a massive MI. All of these traditional questions that we ask, right? Your OPQ, RSTI. Sometimes they'll give you, like, especially if it's a sudden onset, that can give you a lot more information. Gradual onset can be, a cardiac in nature, or it can be, sometimes it's something else. So just make sure you get a very thorough history of the present medical issue, so that you can, make a proper treatment plan. Your traditional patients or your non-traditional patients who don't experience that crushing chest pain, right? We talked about this already. Women, diabetics, the elderly also, right? They all experience different pain tracks than men do. And again, we talked about this. Men were the ones who were traditionally studied in all of these cardiac studies, because women were kind of hard to, track on their period. There was too many variables. So we just write them off as a population. But a lot of women diabetics, and sometimes the elderly as well, usually lethargy is the number one complaint. Sometimes GI symptoms, right? Nausea, vomiting, indigestion, again, weaknesses, various weakness, right? Just like feeling kind of malaise, is also very popular. Had a DOA once, got called to a member of service's house out in Suffolk, and the gentleman was older, so everyone was anticipating that it was the MOS who had passed away. However, it was his home health aide, and I found her clutching a roll of Tums. And I was like, you must be kidding me, right? Because you hear about this all the time. Oh, the heartburn, heart attack. In her bag, she had paperwork from one of the city hospitals. She had gone complaining of chest pain, and they discharged her with indigestion. They didn't do blood work. They didn't check her troponin levels. They just discharged her with some Tums, and I'm pretty confident that that's what killed her. So, moral of the story, if it's not, cut and dry, sometimes you have to be an advocate for your own health. So, be an advocate for your patients if you think that there is something more serious going on. So dyspnea is kind of one of those symptoms that pops up all over the place. But we're going to talk about it in regards to pump failure, specifically right here. If your heart starts to kind of quit on you, right, one of the number one things that happens is that the beginning of heart failure, that fluid will build up in the heart and then go back from whence it came. Okay, so if it's right-sided heart failure, it's going to go back to the lungs. If it's left-sided heart failure, if it's left-sided heart failure, it's going to go back to the lungs. If it's right-sided heart failure, it's going to go back to the body. You very rarely have one-sided heart failure, because once one side goes, it kind of drags the other side down with it. So if you hear, crackles, or sometimes you won't even hear the crackles. If there's enough fluid in the lungs, you won't hear it at all because it's just full. So if you have like very, very diminished lung sounds, you can also potentially have a patient who has that pulmonary edema that's going on. Nocturnal dyspnea, right? When they go to sleep, they lay down, and they start having a difficult time breathing, especially at night, which, or orthopnea, right? Was laying down and having a hard time breathing. Is commonly because that fluid from the heart failure spreads out along the backside of the lungs and takes up more space than it would if you're sitting upright. a lot of patients who have heart problems will have like a traditional expectation of their shortness of breath, right? So, for example, they might say, oh, well, I can walk up a flight of stairs and then I get short of breath, but if I sit down for 5 minutes or so, I go back to normal. Okay. Well, has anything changed? Yeah, I walked up my flight of steps and now I still can't breathe. It's been a half hour. Okay, right? Something has changed. Um, and all of these things kind of work together to create this situation for this patient. Um, a short, like sudden onset of shortness of breath can very commonly be pulmonary embolus, right? Does not mean that you don't rule it, or a foreign body of a child, but we're not really talking about children. But that means that you're going to be doing a 12 lead, and you can potentially see if there's a strain pattern, which we'll talk about in a little bit. Excuse me. So, and again, like a lot of patients also have like comorbidities. So if you have a patient who's like an asthmatic or COPD and they're complaining of shortness of breath, you have to find out if that's their normal shortness of breath when they have an asthma attack, right? If they're like, this is new, I took my pump, but it didn't help, and whenever I take my pump, it usually helps, and now, this feels completely different. I don't feel tight. I feel like I'm drowning. There's a lot of different ways that it can present, but if it's different than their normal expectations of their previous issues, then that's where you need to be, a little bit more of a detective. The number one reason that people have a syncopal episode is that there is a brief decrease of oxygen to their brain. Okay? And I put the church faint in here because it's actually true. People get a little worked up in church and they actually do faint. Also, I don't know if anyone was brought up Catholic, but those early morning masses, people tend not to eat breakfast before they go to mass. I don't know, I was brought up Catholic and you weren't supposed to mix breakfast and Jesus. So like if you were getting communion, you couldn't have breakfast. You could have breakfast after Jesus, but you couldn't have breakfast before Jesus. So people go into church, they might be a little hypoglycemic, they might be a little dehydrated. If it's hot, they might get touched by the spirit. Sometimes that people get worked up and they have a decreased oxygen to the brain. Sometimes a lot of these things can also precipitate dysrhythmias, right? You got those little old people who go into church, they might have AFib. Maybe they didn't take their medication yet because you don't want to mix Jesus and your beta blocker. So maybe they have AFib and that not taking their beta blocker or their amiodarone or any of their other, rate controlling medications puts them into a tachydysrhythmia. Okay? A lot of different things can happen. In general, if you have a patient, especially the elderly patient, who just has a random syncopal episode, you'd better be doing a 3 and a 12 on them. Okay? That's the number one thing. Syncope 100% needs a full workup because you need to make sure that there isn't an underlying cardiac event. Had a lady once, we found her she lived in like a condo on the second floor, and there was a landing between her steps. So she had banged on the wall because she had fallen down about 6 carpeted stairs and landed on her arm. And she was laying there for a few hours, couldn't get herself up, and she started banging on the wall to get her neighbor's attention. So her neighbor finally was like, what is going on? Went over and was like, oh my God, she's on the floor. So they called 911. We get there. Put her on a 3 lead, put her on 12 lead. As we move her, she goes into a run of VTAC. And she had no recollection of how she fell down the stairs. She just she goes, I don't know, I blacked out and I woke up on the floor. And I was like, aha. Perhaps this, she had a run of VTAC and had a syncopal episode and fell down the stairs. Just make sure as you get older, you live in a 1-story building. You don't want to live somewhere where there's lots of stairs or a basement because, we all know how that goes. Anyway, so this is why we do these workups, right? Because you could have these cardiac dysrhythmias that create a syncopal issue because of decreased output from the heart. There's a number of other things, right? So, if you have a patient who is an AFib or took too much of their blood pressure medication or has any other comorbidity, a lot of these things can kind of pop up and create a decreased output and cause a syncopal episode. Also, patients on the toilet, most of the time, all right, they bear down too hard, they vasovagal themselves out, their blood pressure drops, their pulse drops, and then they pass out in the bathroom. And this is how you end up with 360-pound patients in between a toilet and a tub. Welcome to my TED Talk. This is a kind of fun little chart that gives you an idea of the difference between the correlation between how your EKG might look, right, where your bradycardia, tachycardia, and the cause behind syncope, right? So, for example, if you have a patient who is tachycardic, it could be drug induced, right? So maybe they bumped a line of cocaine, they gave themselves tachycardia, it dropped their preload, their cardiac preload, therefore they had decreased cardiac output, and they passed out. Okay, we talked about bradycardia already, right? So if they vasovagaled themselves, they could bring their heart rate down and again decrease their output and cause a syncopal episode. So there's a lot of different relationships between heart rates and the well-being of the body overall that can cause, syncope. Syncope is going to, you're going to see it a lot. It's very, very common in the pre-hospital care setting, right? Let's just keep that in mind because you really have to make sure that you do a good workup. And that also includes orthostatic vital signs, right? Orthostatic vital signs being that there is a 10-point change in the heart rate from laying down to sitting up, as well as a 10 to 20 point decrease of blood pressure from laying down to sitting up, okay? That means that patient's hypotensive, which means we can fix that to a certain degree, right? We give them some fluids, but that also means that you need to investigate further. Are they experiencing a GI bleed? Do they have a heavy menstrual cycle? Did they not drink in the hot weather? There's a lot of different things that can cause that, and we can kind of manage that appropriately pre-hospitally. Palpitations. A lot of different things can cause palpitations, a feeling of palpitations. Sometimes it's a very fast heartbeat. Sometimes it's a slow heartbeat where they feel that skip, right? So they might be in a second degree type 2 or type 1 where the beat gets dropped and it feels like a palpitation, right? Like it skipped a beat. You want to make sure that, this is where you're making sure you're getting a good solid pulse, okay? Because just because what you see on the monitor doesn't necessarily mean that that's what the patient's experiencing mechanically with their heartbeat. So you want to get a good pulse. You want to ask, again, a good history, right? Any medications, alcohol, cocaine is always popular, meth, other medications that they should take, any other associated symptoms, right? So just because they're feeling a palpitation, are they getting dizzy? Are they getting nauseous from it? How long does it last, right? If the palpitation only lasts for a few seconds, that's one thing. But if it's continuous, then, that could be something else. You want to make sure, of course, that you're getting this patient onto the cardiac monitor. You also want to make sure, is there something that brings it on, right? Oh, well, I run and it starts to feel like I'm having palpitations, or I sit up and I feel like I'm getting palpitations, right? Because that brings you back to orthostatic changes potentially. So a lot of different things that you need to investigate when you're looking at these different subcategories. I think my favorite quote-unquote classic presentation for a severe cardiac issue is the impending doom. I've definitely seen it a few times with patients like, I'm going to die. And they're like, not in this ambulance, you're not. Stop that. But the quote-unquote classic textbook presentation for a cardiac event is that substernal pain and discomfort is usually radiation to the arm, traditionally the left arm, and it needs to last more than 30 minutes. Okay? Even if it doesn't last more than 30 minutes, because most of the time if it's that severe that patients are calling, 911, if it's severe enough that they're calling 911, then, obviously you need to make sure you take it seriously. Um, a lot of other things, right? Diaphoresis. I think everyone's seen that patient who's just sitting there sweating, and you're like, you okay? And they're like, I don't feel good. Um, Nausea, vomiting, because sometimes if the heart is ischemic, then it can irritate the diaphragm, which sits right on top of the stomach, so that can kind of irritate the stomach as well as decreased oxygen from decreased cardiac output can cause that, the nausea, vomiting as well. Uh, a lot of different descriptors, and again, this is going to depend on the neighborhood that you're working in, because some cultures describe pain differently. Like working in Jamaica, Queens, we have the large Guyanese population. They would always use splinters, like, oh, it feels like splinters, like that they were like be like almost like a pins and needle like poking pain. Um, Meanwhile, you might have other people, oh, if it's like a crushing pain, or it feels like there's someone sitting on my chest. There's a lot of different explanations for what pain feels like to people, and it's going to be based on their like life experiences. So just because it doesn't necessarily sound like something that you've heard before doesn't mean that it's not real. It means that you should investigate it a little bit further and kind of get clarification on what those pain descriptors are, and what it means to that patient. The physical exam, you could find a lot of really different, like cool, different things, in terms of what is going on with your patient. This goes back to kind of being a really good detective with a big old box of medications. So when you're looking at your patient, you might see, right, that big old scar down the middle of their chest, right? They've most likely had heart surgery if they've had a sternotomy. Occasionally, it might be that they've also had, like, I don't know, a lung transplant or something to that extent. But most of the time, kind of run-of-the-mill surgery is that there was some sort of cardiac surgery. What they're doing now is they're doing the mini incisions where they're going in, laparoscopically in order to do some repairs, which is a lot better for the patient because there's a lot less downtime. Because think about it, you don't have this big old zipper wound on your chest. Patients have had sternotomies and coughed. Like, I don't know if anyone's ever seen, like they give those heart patients a big pillow, and they're supposed to squeeze the pillow when they cough, because after the surgery they are going to be coughing a bunch because they've been intubated and their lungs are kind of like figuring out like what just happened. Um, so they tell them that they have to squeeze the pillow when they cough, because if they don't and they let their chest kind of expand as fully as it wants to, they can pop the incision on the inside and they can end up with their heart herniating out of their chest cavity. I've seen it once and it's pretty wild. Um, Definitely 10 out of 10, do not recommend. Patient was in a lot of pain and had to then have then they had to be reopened and then like sutured back up to put everything back where it was supposed to be. So something that you could potentially experience. Um, Edema, right? We talked about this, right? Heart failure really traditionally shows up, with gravity dependent edema, depending on how that patient spends most of their time. Um, Skin color, temperature, and condition, right? Are they ashy gray, where you're like, that patient doesn't look well? Or are they like more normal colored? Are they cyanotic, right? There's a lot of different things that you could be experiencing. JVD, never really a good sign. Um, I don't know if anyone's ever actually witnessed a patient in JVD before, but it can get really significant where that jugular vein is really protruding. Uh, Implanted devices, right? It's always a good idea to do a quick sweep under those the clavicles, to see if there's any implanted devices, right? They might have a um, a pacemaker, they might have an AICD. They're making them smaller and smaller, so it's actually a lot harder to feel them under the skin because they're really trying to make them small and less noticeable. Medication patches, nitro is a commonly seen one. Pain medication patches are also always kind of popping around these days. Sometimes you might have a patient who's kind of looking like crap, and you take their pain medication off, and all of a sudden all of their cardiac symptoms go away, right? If you suppress their oxygen significantly enough that they're kind of hypoxic, that their respiratory drive. If you suppress their respiratory drive enough that they become hypoxic, they can present with cardiac-like symptoms. Heart and lung sounds always good to listen for. You're not going to practice probably as much with heart sounds as much as you do with lung sounds, but you can listen and you can get a good idea of what's going on in the heart if it's doing your standard lub dub or if it's doing something a little different. Heart sounds are also really helpful for really young children. If you are having a difficult time palpating a brachial pulse, you could also listen to get a rate. Just remember, lub dub is 1. So if you're, you don't want to count every single one because that's going to look like they're super tachycardic. Any questions before we move on?
No.
Nah, that was very. I speak for us all. Nah, we good.
I was like, oh, I don't.
All right. So, acute coronary syndrome. Okay, this is kind of one of the reasons that pre-hospital care kind of got its start after the whole trauma thing. When they started to go, hey, I wonder what else these guys can do on this ambulance. Let's give them a cardiac monitor so we can detect heart attacks in the field. Acute coronary syndrome kind of applies to anything dealing with chest pain. Okay, so stable and unstable angina as well as an acute MI. And yes, I know we just covered the fact that acute MIs don't necessarily produce chest pain, but, male studies only. Acute coronary syndrome, how they always say on the news that he was like a person, they died by cardiac arrest. No, like that was just the end result of something else happening, right? Like in the out of hospital setting, acute coronary syndrome and acute MI is one of the most commonly seen causes of death. Especially like just cardiac, like the cardiac death, right? So the heart is going to get damaged by various plaques, and then if it gets worse and worse and worse, and you throw either a thrombus or you overdo it, you can put yourself into real cardiac arrest. So basically, what happens is, and not to really make everybody really sad, but this is happening in everybody's bodies right now. Your body lays down fat. Okay. I'm not going to try to say the plaque name for it, but it starts to lay down layers of fat in your blood vessels, also in your in the heart, which is really what we're talking about right now. But it can happen anywhere in the body as a whole. So these fatty streaks tend to start to stiffen. And as they start to stiffen, the blood vessel gets less elastic. As you start to put stress on the heart in one way, shape, or form, it could be emotional stress, it could be physiological stress. The lack of elasticity can cause the plaques to rupture, okay? And as they rupture, the body does what it's supposed to do, right? It goes in and it tries to heal it. So it sends blood to the area to create a clot. And if there is an adequate amount of space within the blood vessel, then, no big deal. Life carries on. The area will heal, the thrombus will dissolve, and, blood goes round and round. However, if you get to this point towards the end where you have a healed plaque, if this ruptures, and it creates a thrombus of this size, as you see here in the middle, your blood flow is going to potentially be cut off entirely, which is going to lead to chest pain, secondary to your heart muscles screaming for oxygen, right? So that ischemia, injury, infarct route that the heart ends up taking. You'll see EKG changes, right? And this is why, we give the patient aspirin, is because we want to reduce the size of the thrombus that's being created in this process. And aspirin, again, we're reducing the amount of myocardial necrosis that's going to happen. We are going to give nitro to try to dilate those blood vessels so that the blood flow continues, okay? You want to make sure that anything that you're doing is improving that left ventricular function without over exacerbating the workload on the heart. Okay, so hold on, so if this is the traditional oxygen, aspirin, nitro treatment goals. Okay, it's not. Acute coronary syndrome is not terribly difficult to manage. The more difficult part of it is discovering what it is, right? Because there's also a lot of other things that could potentially mimic it, right? You have a patient who's having, passing a gallstone. They could be having severe epigastric pain that might mimic a heart attack. And you give them aspirin, you give them nitro, and it doesn't really do anything, because it's not really for their heart. Side note about nitro, and it's actually an interesting conversation I had with a doctor once. We were talking about how nitro is supposed to dilate your blood vessels. And he was saying, yeah, it works, and it's pretty impressive with how it works. The problem is when you get to the point when your blood vessels have so much plaque in them, that blood vessel has already dilated to its maximum in order to allow normal blood flow. So you have a blood vessel that is now extended as far as it can, like a balloon about to burst, and you're going to give it nitro, and it's going to look at that nitro and go, yeah, okay, bro. Nah, I got no stretchy left for you. So when we talk about, did the patient have relief with the nitro, you might give a patient nitro and they might have no relief because they're just out of stretchy. Okay, so keep that in mind, because a lot of medics will use I gave them nitro and they didn't have relief as like validation that it's not acute coronary syndrome. Just kind of remember that the next time you have a patient who you see is dealing with chest pain, that it might not help because that blood vessel is just stretched to the max. Moving on. I hope y'all didn't eat breakfast yet. This is the inside of an arteriosclerotic vessel, okay? So when we say, they went in and put stents, they take that little balloon, they squeeze it through this goopy, like, kitchen sink drain glop that's lying inside of your blood vessels, and they open it up. Patients who've had a stent can have complications afterwards, because think about it, just because you kind of smushed all of this stuff to the outside doesn't mean that you might not have broken a bit of it off and is now wandering about the body looking for a new home. It can cause a nice stroke or something. Y'all are blowing up the chat right now. So again, talking about how that lumen of that blood vessel gets narrowed and might not be able to stretch any further. This is why, right? It's full of goo, not a sexy look. Arteriosclerosis can happen absolutely anywhere in the body, okay? And if you have coronary artery disease, it's very likely that you also have arteriosclerosis other places. Like, your body doesn't just pick and choose, like, ooh, the heart looks real cozy, we're just going to put fat here. you'll see that patients who have atherosclerosis and coronary artery disease also end up with peripheral vascular disease through the same exact mechanism, right? But now, instead of you losing, heart muscle, you may be losing, calf muscles, right? Or you're losing blood flow to your toes, or, you have pins and needles in your hand because, the blood flow is being cut off. So, if you have a patient who has any of these complaints, it could extend, and they're like, oh yes, I have coronary artery disease. Just keep in the back of your mind that this is potentially has been extended to the rest of their body. Also, the aorta, right, and the carotid vessels. Has anyone ever seen the patient who's had their carotid vessels roto-rooted? So if this atherosclerosis builds up in the carotid arteries, right, they'll have a decreased blood flow to the brain, which means that they're going to have really high blood pressure because the heart's going like, why can't we get oxygen to the brain, people? We have to pump harder. So it'll start to try to pump harder. But you'll have all of this plaque back to here in the carotid. So they'll go in and they'll cut the carotid open and they just scrape all of that out. Gross. Commonly, this atherosclerosis is found in turbulent blood flow areas because if you think about it, you ever look at like whitewater rafting and you see where the blood or the water starts to kind of tumble and you get all the wood and leaves and stuff that's sort of stuck in that one area where it's very turbulent. That's exactly the same thing that's happening in areas of turbulent blood flow in the body. Okay, it's kind of, there's a word for it, and I'm blanking. I'll think of it. So that turbulent blood flow, not only does it cause that buildup, because now the fats in the blood are just kind of staying in that one area, but it also causes some damage to the endothelial cells, so it induces that sticky platelets because they're trying to do their job, right? And they're going to create a scab in order to reduce damage. So those sticky platelets get sticky enough where they also get sticky to that fat that's in the blood vessel, and it just lays it down. The vessel gets less elastic and more likely to clot. Questions?
Is there a medication to break that up?
To break it up, no. Once it's laid down, it's down. It's can be reduced to a certain extent through like diet changes, or at least that's what some of those, some doctors are claiming. But it's about, eating your vegetables and having all those proper nutrients in the bloodstream. There is a theory also that very low density cholesterol, so like you have, very high density cholesterol, you have your LDL, which is your lousy cholesterol, your HDL, which is your good cholesterol, and then they have very high density cholesterol. It's like really, really small molecules of cholesterol. There's a theory that though having an adequate amount of that in your blood actually helps reduce your LDL, that it quote unquote eats it. So that also can help potentially break down these plaques. But I don't know where the research on that is. It was still being theorized about 6 to 8 months ago when I saw that last.
So Nicole, I have a question very quickly.
Mm-hmm.
So in regards to nitro administration, I've heard a lot lately about, okay, very careful giving it in right-sided heart failure, but given that we can't really diagnose the two, or the two are often mixed together, I mean, what's the chief criteria for either administering or not administering nitro? Is it going to be blood pressure or use?
So yes, it's going to be a combination of things. So if you suspect a right-sided heart attack or MI, and you move your V4 over to the right side and you do another 12 lead with V4R and you have elevations, very, 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 very cautious in the use of nitro, because that means that right ventricle is involved. If you move it over and there's no elevations in that lead, proceed with caution, but not as much caution is necessary. But again, it also depends on where your patient's blood pressure is. So if they're like 180 over 90, you have a little more wiggle room. If they're like 110 over 70, again, much more cautious. This is also a patient who I wouldn't necessarily give nitro to without an IV in place, because you don't know how that patient's going to react to nitro. Because some patients, you give it to them and they drop 2 points. Some patients, you give it to them and they drop like 60 points, and you're like, whoa, like wasn't expecting that. Now the patient's dizzy and the patient doesn't quite feel right. And if you have an IV in place, at least you can react a little faster than having to like find a vein. And if they're really hypotensive now, maybe they're, that vein is collapsed and you're not going to be able to get a good IV. A lot of things to think about.
So if we made the determination that it's not safe to give nitro, would it be a good idea then in terms of pain to move to an analgesic?
So
given certain circumstances, of course.
I'm going to say absolutely.
Okay.
Back in the day, morphine was in the protocol, the ACS protocol, because morphine also does have venous dilatory effects, but they took that out. However, that does not mean that you could not call and get permission to administer pain medications. You say, listen, like I have a patient, I've got elevations in V4R. I don't want to give them nitro, but I'd like to give them something for pain management, like, maybe fentanyl. And you can see if they'll give you permission. And again, that's going to really depend on the doctor who you get on the phone and their philosophies towards pain management.
So basically, I mean, and I was sharing with the class last night, we actually had a right bundle branch. This is what came across on the monitor, but it was a guy without a pacemaker, with a pacemaker rather, which was not working. He was a regular flyer, but last night he definitely had an issue because he was dealing with an inferior infarct, right bundle branch block. We gave him the aspirin.
Mm-hmm.
The blood pressure was around 130, so no nitro. So, I guess what I'm asking is, pretty much, we should be trying to get a right-sided EKG under these kinds of circumstances?
Yes.
Okay.
And a lot of people don't really think about that or remember.
Yeah, we didn't do that last night. It wasn't really too much time for that. I mean, we were kind of concerned with what was happening. We did have ALS on board, and she was not feeling too well. She was also undergoing some issues. It happens, so happened, but we got him there. But we skipped on the nitro. We just didn't do it.
Okay. So yeah, that one I would say, like, in the event that he had an IV in place of blood pressure at 130,
Which he did.
I wouldn't be too worried. So again, yeah, but you have to play to your patient, not, you have to make sure that they're okay.
He was chest pain 9 out of 10.
Yeah.
It wasn't really relieving.
Okay.
And he was at the hospital. He was again confirmed inferior infarction.
Yeah. So basically, like with that situation, like just moving that one lead, that V4 over to V4R, you could probably get a really good view to see if there's any right ventricular involvement, and if there isn't, you're golden in terms of treating it. What was the write-up in terms of why, the validation of why they didn't give the nitro on the ACR? Did they do a good job documenting?
I haven't seen the PCR yet.
Okay.
Don't know that, but just may have been being conservative. But I can follow up on it.
Yeah, I'd be curious to see how the medic validated that, because like that's a I guess slippery area, because some people are really good at that, saying like, oh well, in an abundance of caution, like, it wasn't given, or patient was hypotensive. This one, I don't know if there's a great validation for not giving the nitro, especially if it's a 9 out of 10 pain.
Okay.
Any other questions, thoughts? All right, cool. So, talking about chest pain, angina pectoris, right? This is the traditional textbook Latin and or potentially Greek, don't quote me on that, definition of chest pain, right? Angina pectoris, chest pain, is caused when there is an imbalance between how much oxygen the heart is requiring and how much there is available. So chest pain can be caused, in this unit, obviously we're talking about STEMIs and stuff like that, but patients can have chest pain for a number of other reasons where the supply and demand is off. For example, if you have a patient who's severely anemic, they might be experiencing severe chest pain, and it has nothing to do with a blockage. Okay, so just keep that in mind as you're, evaluating your patient. If you're doing all this workup on them and you're like, wait a minute, I don't have any elevations, I don't have any other indicators that they might be having a heart attack, you need to open up, your field of vision and look at a bigger picture, because maybe there's something else going on. Maybe they are having a severe GI bleed and their blood, their blood pressure is so low, or their, red blood cell count is so low that they can't give their heart the oxygen it needs. Commonly, what we do see, though, is that it is caused by atherosclerotic disease. There we go. Having a tongue problem there. But you can also have other things such as Prinzmetal angina, which is probably one of my favorite medical terms, Prinzmetal. It is a spasming of the coronary artery. So rather than it being caused by a physical blockage, the artery spasms down on itself and prevents blood flow. It's just like your heart's just having a bad day. It's like, no, I'm done. It can look just like an MI, and then they go in and they have like squeaky clean coronary arteries. And they're like, those medics lied to us, and you're like, no, look at my 12 lead. It's wild. There's elevations. Don't be mad at me. Be mad at the patient's heart. So there's two types of angina, right? You have your stable and your unstable. We talked about the stable one a little bit already, right? I walk up a flight of stairs, I get a little chest pain, I get a little short of breath, I sit down, it goes away. Or I take a nitro and it goes away. Unstable is, well, I don't usually get chest pain just sitting here watching TV. That's new, okay? So when it sort of transitions from very predictable to doing weird things is when it sort of moves into that unstable range. And when you have that unstable thing, that means something has changed with the patient's condition. It could be that they stop taking a medication. It could be that their cholesterol's a little high. It could be just those holiday blues again. But this is where your time to shine and do a great patient assessment. The money call, right? This is when you're taking that patient, you're going right up to the cath lab and you're high-fiving your patient afterwards, or your partner afterwards, for a really good call, right? MIs are caused by, almost all the time, by a blockage, okay? Rare occasions, they're actually caused by a dissection of the coronary artery, which is usually seen in much younger men. Doing those heavy lifting when you shouldn't be doing those heavy squats, is one of those kind of sidebars. But as we're learning here, it's going to be that there is a total or a near total occlusion in a coronary artery. So if you look at this EKG, is your patient having a good day or a bad day?
Bad.
Bad.
What part of their heart is having a bad day?
Anterior?
I heard anterior. What else?
The septal.
A little bit of septal, yep. V2, septal. V3, V4 is your anterior. Where else is having a bad day?
I want to say inferior, but I'm not sure.
So the inferior, those are your reciprocal changes. So you see how your elevations here, and I'm going to give it away now since we're talking about it.
Low lateral.
There you go. The lateral wall, V5, V6, lead 1, and AVL. That's your lateral wall. If you actually take, if you have like an iPad or something, and you take your iPad and flip it over, AVL is the mirror image of AVF. So that damage in the heart is creating what I like to call like a window. Okay, so you're looking right through to the other side. So when you are on the other side, the opposite side of your lateral wall is the inferior wall. It's going to be mirrored the damage that's occurring on the AVL side. So that drop where that J point drops really low and it's bringing that your ST segment into a depressed area, that's a reciprocal change from the damage that's going on the lateral side. Make sense?
So Nicole,
Yes.
so when we were getting told about the 12 lead, I was trying to get confirmation whether or not, so it's 5 millimeters that is significant. Anything less than that, is it still considered something notable?
So 5 millimeters is Scarbosa criteria, which is just left bundle branch. In evaluations for a regular old rhythm, it's 1 millimeter or more in 2 or more contiguous leads. So one tiny box.
Gotcha. So anytime there's like a millimeter or anything like a millimeter or anything like that, then it's considered significant as well, as long as we're not going for Scarbosa.
Yes.
So
go ahead.
I'm sorry. So two things. One is more of a technical issue with the strips we've been getting, like in the worksheet. So with regard to like some of these elevations, it's tough to see in the worksheet. I mean, the quality of the strip. That's just an observation. The second thing I had a question about was in the worksheets as well, and you're kind of addressing it, is the area of the actual coronary artery that is being impacted by the occlusion, which lead relates to that. I'm a little soft on that after the workbook. I mean, I figured it out, but maybe you could focus in on that a little bit at some point.
Sure, here, we'll do it right now. And bear with me as I swap between colors a little bit so that I can make it a little clear. So you have your V1. Oh, sassy. Hold on. There we go. All right, so you have V1, V2, right? These are your septal leads, septal leads. Sorry, small brain fart. Okay, the septal wall is your left anterior descending artery. You have V3 and V4. I'll put it over here, it's easier to see. Is your anterior. This is also your left anterior descending. Okay, so this guy up there. You have V5 and V6, as well as 1 in AVL. Okay, and I'm going to put it over here on the right side. This is your, so these two over here are your low lateral. And these two over here are your high lateral, just a slightly higher part of the heart. Same wall, just slightly different segments. And this is brought to you by your left circumflex. Okay.
Both of them.
Yes. Okay.
So the limb leads, and I don't mean to jump ahead of you here,
ahead.
but like the main so I'm having trouble with it now, but the top artery, the thoracic artery, the top artery that comes out. I'm having a brain fart now.
Go ahead, it's contagious today.
Yeah, so the top artery that comes out of the heart, that would be a limb lead, because that was in there about what artery was covered by the limb leads, like lead 1 or lead 2.
Lead 1 or lead 2. So, well, let me finish this one real quick, and maybe that'll give you
Sorry.
the answer, because I'm not really sure what the question is. So, let me see. So, then you have your limb leads, your lead 2, 3, and AVF, which is your inferior wall. And this is brought to you by your right coronary artery. So I'm thinking what your question is what the artery is higher up.
Yes. Just how the leads relate to not so much the area of the heart that is being impacted, but now specifically the arteries, because that was a question.
Do you have the question?
No, that you answered the question. That's exactly what I needed.
Okay.
What relate to which arteries?
Okay, good. All right.
Thank you.
No problem. So, and let's look at this a little closer now. So, right, remember when you look at 12 leads, you want to make sure you're at that isoelectric line, and then you want to identify your J point, that transition from your QRS complex to your ST, okay? ST segment. Hold on, I'm having a logistical keyboard issue over here on my side. There we go. So if you have, look at that distance, right? From here to here, that is what we call a bad day, okay? This patient is going to need some stents, okay? Just without a doubt. When we talked about pathological Q waves a little bit, this right here is potentially well on its way to being a pathological Q, as is this one right here. See that? Okay. Bad day all around. 10 out of 10. Recommend stents. Any other questions, real quick, before we move on?
AVR. What is that pertain to any coronary artery?
So the AVR is pretty much looks at your I don't know if you can see that. It looks at the aorta. That's super bright. So this primarily looks at your aorta and is a little higher up. So we really don't use the AVR lead diagnostically. The only thing that we really do is if your AVR is not negatively deflected, the patient's serious. Okay.
If it's positively deflected, would it be an aortic aneurysm?
Potentially. Okay. Any other questions? All right, cool. So when you have this occlusion in the coronary artery, and if you look at the picture right here that is presented, give me my pen back. Right, so if you look right up here, right, this is your left anterior descending. Okay, this back here is the inferior wall. Okay, right, so here's like your left ventricle. Left anterior descending. Here's your left circumflex is going that way. So if you were to have a 12 lead for this particular patient, where would you see elevations with this damage?
Sorry.
Go ahead.
V3 and 4.
Okay, so V3 and V4. Any other leads you might suspect there might be some damage?
V1 through 4, right?
V1 through V4, perfect. Okay. And again, this is going to depend on where this clot is. So like if it's the clot's all the way down here, you might only see it in V3 and V4 because it's more in the anterior, potentially in the anterior side. If it's all the way up here, you might have elevations throughout all of them. Okay, so good. Without, hold on one sec, come in. Hold on one sec.
Hello.
I'm back. All right, so if you don't get this circulation restored, this muscle just dies. It's donezo, okay? However, the older a patient is, we have what we call collateral circulation. Okay, so collateral circulation is really helpful because as you get older, if there's like a tiny little microclot there, your heart goes, that's not good. I'm not getting enough oxygen where I want it, right? So it will make extra vessels going around. And this is part of the reason that you don't necessarily, the older a patient is, the less likely that they might have that really severe crushing chest pain, because if this occlusion right here finally goes done, it's not going to be as extensive an injury because you have this collateral circulation coming around, okay? So just one of those kind of interesting, topics of interest where you're like making sure that you see all the full picture of your patient. Again, we talked about this previously when you're looking at your 12 leads. So your patient will go through a various progression in their EKGs. This is why you need to get a 12 lead, and this is why it's always wise to get multiple 12 leads as you're transporting, if possible, because you can kind of track the progression of the injury, or you can see how well your treatments are helping, okay? Because if you give them nitro and it starts to get better, you're on the right track. That's a good thing. You should assume that any patient who has anginal chest pain is having an MI, and let the hospital figure it out, right? They're going to check for troponins. That's their job. Let them make a decision one way or the other. You do your best in the ambulance. PCI, right, or percutaneous coronary intervention, or as we like to call it, stents, or the cath lab, is when they use the little magical balloon to reopen those blood vessels that have been closed. We do talk about the possibility of dysrhythmias, right? Because now you have this irritated, pissed off, injured part of the heart that's now getting oxygen, right? Which is why sometimes it's dangerous to give your patient too much oxygen, because now you're pissing off this injured heart muscle and the patient can die from freaking VFib after you did all this hard work to keep them alive in the first place. Another thing that they also potentially will do is they'll do fibrinolytic therapy, sort of like how when a patient's having a stroke, if they suspect that it is in fact caused by a thrombus as opposed to a plaque issue, they can give the patient fibrinolytic therapy to dissolve the clot. Most of the time they will do percutaneous or PCI because it's just a definitive. It takes about 8 weeks for necrotic tissue to form a scar tissue. So in that time frame, those patients are kind of expected to chill. Okay, they need to not really exert themselves. If they do, that wall of the heart can rupture. Okay, sounds like a blast. Would not recommend. A lot of issues after MI is that, the dysrhythmias, which we talked about, most leading cause of death after being, after having an MI, either with or without PCI therapy, and pump failure, right? So now you have these patients who are long-term chronic CHF patients who need to be maintained, okay? It's just, you should need to keep in mind that you might be experiencing taking care of some of these patients after the fact. Speaking of heart failure, chronic condition, right? Doesn't really get better. It's just managed. Unless, of course, the patient does receive a heart transplant. Fun fact, if you have a patient who is a recipient of a heart transplant, you cannot give them adenosine. When the heart is transplanted, they can't hook up all of the nerves, like the vagal nerve, appropriately. So giving them adenosine doesn't work. It actually will just cause a tachydysrhythmia by accident, which is kind of insane. They require synchronized cardioversion. So bury the lead, trick question. Also, patients who have received a heart transplant very rarely will be experiencing an MI. Okay, think about it. They've got this fresh, clean, new, squeaky clean heart. Okay, that heart's got a little like low mileage on it. It's going to be anticipated to like survive pretty well. Just things to think about if you ever do transport a patient who has had a heart transplant. Heart failure, though, is caused by a number of different things. In the United States, I want to say one of the number one reasons is it's caused by uncontrolled hypertension, unmanaged MIs, right? Patients are like, I have a little chest pain, just kind of hang out and don't do anything about it, and that part of the heart just dies. And severe lung disease, right? COPD can cause a significant damage to the heart overall. Right-sided versus left-sided, I think we've talked about most of this, right? Remember, like, where the fluid is going back to, okay? It goes back from whence it came. So if it came from the lungs, it's going to go back to the lungs. In left-sided heart failure, right, your patient's going to present with dyspnea, potentially some like pulmonary edema, which would give you some crackles in the lungs, versus right-sided failure, where it's going to go back systemically, right? They're going to have gravity-dependent edema in either their pedal region or their sacral region. Their liver might be also distended secondary to fluid overload, okay? JVD is another possible presentation for exacerbated right-sided heart failure. Ooh, too much enthusiasm. Pulmonary edema. All right, so a number of different things can cause pulmonary edema, right? We have our acute pulmonary edema, and then we have our, run-of-the-mill standard brought to you by CHF and poor Lasix management pulmonary edema. Most of the time it's caused by that left ventricular failure, but pneumonia can cause it as well. It's basically there's something causing blood flow compromise through the left ventricle, and it's sending it back into the lungs, okay? This might be due to increased afterload, right, which is usually what we see in acute pulmonary edema. Oh, too much enthusiasm. Or it could be right-sided heart failure that starts to trigger left-sided heart failure. There's a number of different things that can cause it, but your patient commonly presents with difficulty breathing. They might have pink frothy sputum. They might be 1 to 2 word dyspnea and completely full of like bubbles, right? They sound like a bubble machine. Any of those things can cause pulmonary edema, and CPAP is usually the number one way to fix it. Nitrating your patient is also very successful, but pretty commonly seen. The problem with pulmonary edema is it also washes out some of the surfactant, right? So if you kind of think of the alveoli hanging out there, once that fluid gets in, that fluid will wash some of the surfactant away, and those alveoli will, deflate. Not the right word. Collapse. That's the word. They will collapse, right? So you can have a patient who, even if they've had potentially a recent pulmonary effusion that's been drained, they can still have difficulty breathing because some of those alveoli might still be collapsed or atelectasis. Go ahead.
Nicole, I had a question again, and not to harp on this, but with this case we had last night, Again, right bundle branch block. Lung sounds were clear. No difficulty breathing. I'm sorry, I should say no rales or rhonchi, but there was some wheezing. The right bundle branch block, but the fascicular block as well. Is that also indicative of right-sided heart failure? I mean, it's right bundle block, and we have and he was a smoker, so like a COPD type wheezing, but no fluid in the lungs with dependent edema, definitely dependent edema.
Okay, so the right bundle branch block could cause just a conduction delay, which might cause not necessarily failure, but just that delay can create some issue. There is something called cardiac wheeze. Cardiac wheeze is a centralized wheeze that is just literally just because of a cardiac issue. Was there any treatment given for the COPD or that wheezing, or did we just kind of throw him an oxygen and go?
Very minor. He had no difficulty breathing, wasn't complaining of it. But when we listened to his lung sounds, and it might have been his position, it might have been he was morbidly obese. But in terms of the breathing, he really wasn't complaining of shortness of breath. So we didn't go into a respiratory protocol so much.
Okay.
But I'm just really trying to tie in. So the dependent edema, but without the fluid in the lungs, that would kind of tip towards right-sided heart failure.
Yeah, and I mean, he might have had right-sided heart failure that caused a right bundle branch block, right? So if he had any level of damage in the myocardium there that then also affected his electrical conduction pathways, then it could have, again, you're like in that chicken and the egg kind of stage, like which one came first.
Got it. Thank you.
No problem. So the whole concept of treating pulmonary edema is that you want to decrease the oxygen demand of the heart, right? Pretty much anything, like if it's the heart's screaming for oxygen, you want to make sure that you give it oxygen without making the patient work harder for it, right? This is why CPAP is so effective, right? Because all they have to do is sit there and let the oxygen go in, okay? This is why nitro and aspirin work so well, because you give them the medication and the heart can relax a little bit, okay? So if it is in the event of an acute onset where the patient's extremely hypertensive, reducing that afterload, right? Reducing that high blood pressure, which is what we do with nitro in treating APE, helps reduce that pressure on the heart. Because remember, in order to get that blood around the body, that heart has to pump against that pressure. So if you have a patient with a blood pressure of 250 over 120, that heart is pumping against a pressure of 250. Okay, this is why we reduce that work on the heart so it can relax and get the oxygen it needs. So kind of hand in hand with heart failure is cardiogenic shock. Okay, cardiogenic shock can be progressive, where the heart failure just gets worse and worse and worse, or it can be a sudden onset due to a significant MI, where the ventricle is just damaged so intensely that it cannot pump well. Okay. Much like all your other shocks, you're going to see similar issues, right? You're going to have a patient who's tachycardic. They might be a little cyanotic. They'll be hypotensive, right? But in addition to those things, you might also see some level of pulmonary edema, okay? You might narrow pulse pressure, right? So narrowing pulse pressure is when your blood pressures are too close together for the heart to fill appropriately. So if you have a patient who's 100 over 90, that's a narrowing pulse pressure, okay? That heart doesn't have enough time, it doesn't have enough relaxation zone to appropriately fill. So your heart's trying really hard to move the blood around, but that causes it to not relax well, which means that it's not going to fill. This is really where we use our pressors, right? But you need to make sure that you rule out other causes of shock first, primarily hypovolemia, right? And this is why we do in our protocols, we have a fluid challenge. Okay, so you're going to give that patient 250 milliliters of fluid, reassess them, do another 250, reassess them, and then give them the depressor, dopamine or Levophed, whichever's on the on the list for the menu for that day. Okay. There's definitely going to be times when you see a patient, you know that they're going into cardiogenic shock because, maybe they're having a massive STEMI, right? And you're going to skip doing the fluid resus because maybe you know that you're going to have to go right to a pressor. Cardiac tamponade might be one of my favorite cardiac issues. There was a random medical TV show like years ago, and they did the pericardial centesis like on the show, and it was just kind of cool. They go right under the sternum and they get the needle in the pericardium and like drain it out. So your heart does this really cool thing, and this is going to be you can look at my really crappy drawing again. As the heart pumps, it swings back and forth on the aorta. So it's really kind of cool. So your heart's not really attached to much. And we're going to talk about this again when we get to trauma, because the fact that your heart's not really attached to much is why chest trauma is so scary for you, or for your patient. So it's hanging from your aorta, which kind of serves as a swing. So the heart, as it goes lub-dub, swings back and forth. And that swinging back and forth actually allows it to fill and pump appropriately. So in the event that there's some sort of damage, it could be trauma, it could be infection, it could be an aneurysm, or remember we talked about the coronary artery dissection, right? So now you're having an MI due to a dissected coronary artery, plus your pericardium is filling up with fluid. It's a really bad day. So once this fills up, the first thing it does is it prevents that swinging back and forth, okay? Because now there's no swing. It's like tying it too tight, right? So it doesn't have that free flow that it would otherwise have. And the second thing is what it does is it causes sort of like when you have a tension pneumothorax, right? And that pressure starts to push. That pressure is inside the pericardium, right? That fluid has nowhere to go, so it crushes the heart. And if the left and right ventricles can't expand, then they can't pump blood. So as they constrict to pump blood out, this gets closer, okay, until the heart can't expand at all, and there's no blood moving around at all. Pretty wild. Not anything that we can really do in the field for it, except call in a really good note to have a doctor waiting for you. Pericardiocentesis right there on the bottom. Oxygenation, rapid transportation, right? So basically what you'll see in an EKG is what's called electrical alternans. Remember we talked about that swinging back and forth? So because that swing isn't happening, you'll have one small, if you look on the bottom, the blue arrow is one small QRS followed by one larger QRS. And that's because that swinging back and forth isn't happening. So it's affecting how the QRS voltage looks on the EKG. So kind of cool. If you ever do get this kind of patient, you all better send me pictures, okay? Because that's really interesting.
It only happens in lead 2?
It happens all of them.
Okay.
It's just harder. You can't really tell because it's so low voltage. So also as the tamponade gets bigger and bigger, the voltage gets smaller and smaller.
Gotcha.
So it's harder to kind of detect the differences between the two.
Thank you.
You're welcome. All right, aneurysms. Sad stats. 65% of patients who have a ruptured aneurysm die before they ever get to the hospital. You can bleed out from your aorta in a matter of about, I think, 8 heartbeats. It's something ridiculously fast. So, you don't even have time to sign your will before you're dead. Commonly, aneurysms are caused by a weakening in the lumen of the artery. They can then happen in a number of different ways in terms of how they extend in the body. A lot of the times it's caused by atherosclerotic disease. Sometimes it's genetic disorders. Patients who have Marfan's, for example, have very weak connective tissues, and because of those weak connective tissues, they're at an increased risk of aneurysms. Once went to a hospital doing my transport days, went to go pick up a patient he was going from St. Cat's to St. Francis, and the patient was complaining of 9 out of 10 like back pain, right? From between the shoulder blades all the way down. And I'm like, let me go find the nurse. So I go find the nurse. I'm like, question. She's like, what's up? I'm like, this patient, he's supposed to go. Yeah. I'm like, he's got Marfan's. And she goes, I know. I'm like, he's complaining of severe pain between his shoulder blades. Why is he here? Oh, he has a AAA. I'm like, has he been scanned recently? They're like, no. I'm like, she goes, no, I've been trying to get him a scan since yesterday. I was like, okay. The man, they rushed him. They made us wait because they're like, fine, we'll scan him real quick because you have to send him. They brought him down. They brought him back. They're like, yeah, we're canceling the transport. He had dissected from his aortic arch all the way down to his femoral arteries. Pretty wild. But he wasn't bleeding. He wasn't bleeding out because so what happens is you have the different lumens of the artery. So the inside lumen tore, the blood got behind it and just separated it all the way down. So all they saw on the CAT scan was like this big, like if you see right here,
huge vein or
yep, this huge old vein. And the problem with that as well is now once that blood gets out of the main circulation, it starts to clot. So these patients are also at an increased risk of throwing a clot, so stroke, heart attack, etc. Sometimes you'll see the patients will have like a small pulsation by the umbilicus, which is really the AAA, right? So the abdominal aortic aneurysm can happen above or below the kidneys. The thoracic aneurysm is usually right above, like the abdominal aortic is like right around here. This is really what you feel at the umbilicus region. So if you want to use that also as a nice reference point, if you put your hand on your umbilicus, your kidneys are kind of on either side. Most of the time, if a patient does have a rupture, it's all of a sudden they're having severe back pain. I had one patient once who had a thoracic aneurysm, aortic aneurysm. She was complaining of the pain between her shoulder blades, and she had lost vision in her one eye. And that was it. And we tried to sit her up to get her on a stair chair to get her out because her house was like a little teeny tiny staircase, and she just got diaphoretic. And we're like, all right, nope, lay down, put her right back down. Aortic aneurysms are more prevalent, and because of the higher level of pressure, right? So this is coming straight out of the heart. So there's a lot more pressure here than if you work your way down. It's a lot more turbulent here, so it's an increased risk of that lumen getting broken. Aortic aneurysms their severity also depends upon whether or not the root is involved, and by the root I mean the aortic valve. Okay, so if you look down right, that little bump, the little white bump that's involved in this picture here, that's where the aortic valve is. So if the root is involved, remember where your coronary arteries get their blood supply from. Okay, so if that tears there, and you're reducing all of the blood flow to your heart as well. So this patient can not only have a massive heart attack or something that looks like a heart attack because now all of a sudden the blood flow is cut off to the heart, but they could also dissect all the way down. Visual disturbances, stroke-like symptoms, a lot of different things. An aortic aneurysm up in the thoracic region, you'll have different blood pressures between arms. Okay, definitely have had a doctor try to tell me once that it was just due to subclavian stenosis, and I was like, dude, it's like 40 points different. Let's try that again. So, stick to your guns if you do believe that there's a sort of issue going on. because if you look at the arch, if the whole arch is involved, you're losing blood flow to not only like the arms, but the brain as well. So this might be one of those patients who suddenly drops into cardiac arrest after complaining maybe of like some back pain. Other issues. Oh, we had one of these at Winthrop the other day. A lady had an acute arterial occlusion. There is a thrombus in an extremity, essentially. She had a extensive arterial clot in her arm where they had to go in and they roto-rooted it, and they pulled out the clots from her brachial artery and her radial and her ulna. So like, patient was an AFib patient, wasn't taking her blood thinners, decided I guess she really didn't like having an arm, because why would I take my blood thinners? And she had it like her whole arm was like that blue. The problem with this also is now you have issues with swelling because of that blood flow issue. So you'll have like an extremity that's blue, purpley, and very swollen. Depending on what is occluded can cause the differences in the presentation. That's the word I was looking for. AFib, pretty much the root of all emboli issues, except for like DVTs here and there. A lot of the times, if you have a peripheral embolus, it's starting most of the time in the left ventricle. It can also happen up in the artery, the atria, and move its way around. Mesenteric arteries. This is actually one of those like kind of really cool ones. So your entire gut is supplied by the mesenteric artery. A mesenteric ischemia caused by an acute arterial occlusion is very commonly missed because you have a patient with extremely severe abdominal pain with a completely normal CT scan, because it's not the GI tract that's the issue, it's the blood flow to the GI tract. So it gets commonly missed, and to the point where the diagnosis is so delayed that patients actually end up needing to have bowel resections because of the necrosis that sets in. So one of those little things that you should keep in the back of your mind. Pain is, signs and symptoms related, again, where what's occluded. You have to look for changes to the temperature, the skin temperature, color, condition, right? And it would be potentially very isolated. What else we got? Non-critical peripheral vascular conditions. We're going to talk about these really quick. Varicose veins. Varicose veins will create the best murder scene you have ever seen when they blow. Okay, these are little veins that are under high pressure because they're not draining well. So they just sort of start to dilate and dilate and dilate, and all of a sudden, like, they can spontaneously burst, which is just insane. Or they can bump against something and you walk in. I had a lady who had a varicose vein that burst once, and it looked like someone was axe murdered in her apartment. And of course, she was wearing all white, and she was just completely covered in blood. DVTs, if you look here on the second picture, see that shiny, tight-looking calf? That's commonly caused by DVT, right? You get that backflow of pressure because the vein can't drain properly, right? Because they think it's going right back up. So you get a pooling of that blood. The DVT gets larger and larger. DVTs very commonly cause pulmonary embolisms when they break off, which is just not a good day for anybody. It also causes what's called claudication. So if that patient who has a DVT tries to point their foot or bring their foot back up, they'll get severe cramping in their calves. Okay, that's usually a good sign of a DVT. Help confirm it. A lot of these issues with DVT are caused by various predisposing factors, usually bedbound patients, patients who have had a long bone fracture recently, pregnancy, because, getting fat and having a small child stomp on your bladder for 9 months, it wasn't fun enough, birth control and smoking, obesity, any sort of hypercoagulabilities can cause DVTs, but traditionally they are presenting with pain to the site, with edema, Apparently, my
Welcome back, Nicole.
hi. Apparently, lecture's over. Computer.
Is she
The
back?
internet was like, nah, we're
She
good.
says she's the host now.
It says she's here.
I'm here.
Hi, Nicole.
Hi. Apparently, my computer decided it was done with this lecture. Am I still sharing screen or no?
No.
And have you stopped recording as a result?
No, that's a separate program because I'm clever like that.
Got it.
Gotcha.
Oh shit.
All right. So yeah, so DVTs, right, presents with pain, edema, warmth, arrhythmia, right, redness, and tenderness. Hypertension. Hypertension, they keep changing the definition. Previously, it was a blood pressure consistently over 120 over 80. I think they raised it a few, like maybe last year, to 130 over 90 because America. Because as long as we can continue pushing the bar, we're going to do it. Hypertensive emergencies are really like kind of hard to like pinpoint. Basically, you have patients respond differently to different blood pressures. So if you have somebody who's got an elevated blood pressure complaining of a visual disturbance, then I would say that's a good example of a hypertensive emergency. Because there are some people who sit at a blood pressure of 220 over 100 and they're like, I'm good. And you're like, are you though? But meanwhile, you put other people at 220 over 100 and they have epistaxis, they're having a seizure, and you're like, what is going on? So the hypertensive crisis is really dependent upon the patient and the patient's presentation. Most of the time, hypertensive emergencies are caused by a patient no longer taking the medication the way they're supposed to. Sometimes it's also due to if their cardiologist is playing with the medications to try to get it more under control. That's another potential reason. Again, this just talks about getting a very good patient history to understand why the patient's experiencing what they're experiencing. So I want to say that the textbook definition of a hypertensive crisis is when there's end organ damage, right? So either there's like AMS or epistaxis, visual disturbances, right? All those end organs that are not able to function the way they should. Valvular heart disease. Okay. Some patients will have issues with their valves. Could be a genetic thing, like for example, most women have a certain level, like 80% of women have mitral regurg. The valve just doesn't close all the way. As you get older, you could have stenosis. So you cannot have, and this was told to me by a cardiologist, you cannot have stenosis and regurgitation. You have one or the other in a single valve, okay? So if the valve does not close properly, you'll end up with regurgitation because the blood's flowing backwards. It's not like it's being forced backwards, it's just gently flowing backwards. Or if you have stenosis where the valve doesn't open, that blood's being forced against a tight valve. Okay, then that's kind of the definition between the two. Patients will commonly have their valves replaced. If this is an issue, they have two options. So either they can have natural tissue, which is either bovine or porcine tissue valve replacement, or they can have a mechanical valve. The mechanical valve means that they will be on Coumadin for the rest of their life. Okay. The mechanical valve never goes bad. A porcine or bovine valve has a lifespan of about 10 years. So if after 10 years they start having symptoms again, they have to go in and have another surgery. So commonly, if it's a younger person with valvular disease, they will opt more frequently to do the mechanical valve so they don't have to constantly go in to replace it. Older people, they're like, here's this piece of pork. We've made it into a heart valve. So yeah.
Some religions will be particular on which valve they get, right?
Say that again, I didn't hear you.
Some religions will be particular on which valve they get because they can't have pork or whatever.
Yes, I think probably Muslim, I think, is very against pork. So they would potentially be very against having a porcine valve. And I do think that they use bovine for one more than the other just because it fits better. I think so. Like the ones that are traditionally replaced are the aortic and the mitral. So I think I'm not sure which is which. So like one of them is more commonly they use porcine, the other one that's bovine, just based on how it fits in the heart a little bit better.
Okay.
I thought a mechanical valve was like a man-made thing. I didn't know it was from an animal.
No, the mechanical one is. The mechanical one is metal. So that's why
Oh.
you have the two options. It's either an animal valve or a metal valve.
So the one, because there was one time I was taking it just happened to be I think it was a chest pain or something where ALS was coming in also, and right before they got in, I just wanted to get all the vitals done and everything. I was taking the BP, then I just heard, I was like, what the hell is this? And then I was freaked out, and the medics came in like, listen, man, something's wrong here, because I was taking a blood pressure and I heard knock, knock, knock. They're like, oh yeah, it's probably a mechanical valve.
It's this tiny heart troll trying to escape. Yeah,
The
so
heart's saying,
they
"Hi,
do.
Jody."
They click. They do click, and it's very distinctive. It does make a very distinctive clicking, clacking noise.
I've had that before, and honestly, it scared the shit out of me. I was like, "What is wrong?"
I grew up. My grandfather had a mechanical valve, so like I was used to it. I was like, oh, okay, I know what that noise is. It's familiar. So, and one of the reasons that patients also might need to have a valve replacement is due to an infectious heart disease. We talked about this a little bit. Endocarditis is what they call vegetative. So if you look at this really delightful gunky, this right here, that's bacterial vegetation on a heart valve. This is like the heart valve. This is one of the leaflets. If you look kind of here, it's hard to see it, but this is another leaflet of the valve, and the other leaflet's like here, but it's underneath this other vegetative disaster. IV drug use is one of the number one causes of endocarditis. Dental surgery is up there on the legal side of causes of endocarditis. Rheumatic fever is not as common these days, but it also causes a significant damage to the heart in terms of introducing this bacteria. Again, not much that we can do to fix it or really to determine one way or the other between endocarditis and like maybe just regular run-of-the-mill valve disease, except, maybe a presence of a fever. So again, monitor your patient. Pericarditis, I think a number of people have had pericarditis here. When that sac around the heart becomes inflamed, it's very painful. There is usually improved pain when patient either like leans back a little bit because it kind of reduces the pressure on the pericardium. The patient will have diffuse ST elevations. Okay, throughout the entire EKG, there'll be these ST elevations, and you're like, oh no, it's it. No, oh, okay, good. So positionally, the pericarditis will get worse. There might be a dry cough, a pericardial friction rub, which I have not heard. I've heard a pleural friction rub before. It sounds like sandpaper rubbing together. So I'm going to assume a pericardial friction rub is something very similar. Patient will also just kind of present as kind of sick, right? There's some fatigue, some fever, difficulty breathing. Depending on what is causing it, you might see, the patient have a fever or not. Like, right, if it's viral or bacterial, it's going to be different than if it's like a connective tissue disorder. Myocarditis is an inflammation of the heart muscle, not super common. Again, a viral disease or a bacterial disease can get in there, but once it gets in there, it can cause significant heart muscle damage. Again, not much we can do. Manage patient symptoms as best you can. Transport. Cardiomyopathies are traditionally, there's two types. There's the childhood ones, and then there's the ones that you develop over your lifetime. Dilated cardiomyopathy is the most common one, and it's as the heart gets older and it becomes weakened and enlarged. Okay, so remember we talked about how you build a muscle, or the heart muscle stretches, and it stretches to a certain point, and at that point is when it's the most able to move blood around. This heart has stretched and stretched and stretched, and now it's just sort of like a sad floppy rubber band. Okay, not effectively pumping blood, caused by a number of different issues. Muscular dystrophy, I've seen that few times, right? The muscle can't build the way it's supposed to because it's being broken down by its autoimmune disease. As opposed to restrictive cardiomyopathy is now you've built up this really strong muscle, but this muscle becomes super stiff, usually due to scarring. It can happen after a heart transplant. It could happen due to various autoimmune issues, right? And that muscle wall just gets stiff. Hypertrophic cardiomyopathy is when you're building up that strong left ventricle, but it just keeps getting bigger and bigger, making the size of the left ventricle small. Commonly seen in younger children. Okay, this is the kid who just drops dead all of a sudden, like no one knows what's going on because no one thinks that they have to check for a cardiomyopathy. Very much a genetic issue. Cardiomyopathy, right? There's a lot of shortness of breath, just like with any other potential cardiac issues. Fatigue, okay? Patients, especially the younger patients who are suspected of having it, aren't able to do the things that you'd expect a normal, 12-year-old to do. Might have fainting, right? Because again, syncopal episodes are closely associated to the heart blocks, not enough oxygen getting to the brain. So if you have a left ventricle that's not operating effectively, then you're going to have fainting spells. Swelling in the legs or abdomen, right? Same idea. The fluid's going back from whence it came. So if depending on what side of the heart is experiencing the cardiomyopathy, which is usually I think both of them, then you're going to have that edema. So various techniques for cardiac emergencies, right? We know all about EKG monitoring and looking at what's going on. We have our different pharmacological treatments that we can use. Defib, we should be super familiar with that one. And here's the two new ones that we're really going to talk about, is synchronized cardioversion and transcutaneous pacing. So EKG, right? You want to keep a good idea of what's going on with a patient, especially if something changes while you're traveling. These are some of the medications that you should be familiar with in terms of your cardiac protocols. Highly recommend looking through your cardiac protocols, because as you move through your skills lab, you're going to need to know those, especially since you're doing your cardiology skills first. Defib, right? You're going to put the pads on the patient. You're going to shock at the patient. Make sure you put the pads in the right spot. Okay. There's two different types of monitors, right? We have the monophasic monitor, which just delivers a single direction of electricity, which needs 360 joules, versus a biphasic, which goes in both directions and hits the heart like a 1-2 punch, only needs 200 joules in order to be effective. The more times that you defibrillate a patient, the less thoracic impedance that the monitor, the defibrillation, experiences. So you don't necessarily need 360 joules on a monophasic monitor after the 10th defibrillation. Okay, it doesn't take as much. The electricity has burned a little pathway through the heart. You're just making hamburger meat, but it doesn't require as much electricity to convert. So synchronized cardioversion is different than defibrillation. Okay, the name itself should kind of give you an idea. It's synchronized, so it's taking advantage of hitting the heart at that repolarization area. So you're going to use it for VTAC with a pulse, SVT, and AFib or AFlutter with rapid ventricular response. You will start at 100 joules and you will work your way up by 100 to 200 to 300 to 360 if a lower joule setting is not successful. There's a little button on the life pack that says sync. When you sync it, the monitor starts to mark where the R waves are so that it can time the cardioversion appropriately. Because if you are on T phenomenon it, right? Remember we talked about that a little bit. If you hit a large amount of electricity at that relative refractory period in the T wave, you're going to put the patient into VFib. And then you're working up an arrest when you didn't really have to. So it's using a little bit of a lower energy to kind of help reset the heart. The monitor has an algorithm to ensure that the timing is appropriate, because you're not going to sit there and go, yes, now. It's just not, you're not going to be fast enough. I'll send you guys the links to this one and this video a little bit later, so that you can watch it. It's pretty wild, synchronized cardioversion. So that's if your patient has a very fast tachycardic heart rate. If you have a patient who is extremely bradycardic, you're going to use transcutaneous pacing. This is using a moderate amount of electricity to stimulate the heart to beat when you want it to. So this is going to be for your symptomatic bradycardias that don't respond to pharmacological therapy, high degree AV blocks, and AFib, A-flutter that have a very slow ventricular response. So when you put the pads on, you will set the pace. When we teach you, it's going to be anywhere from 60 to 80 is usually what we set it at. And then you will increase the millivoltage until you have taken over the heart. Okay, so when I say you've taken over the heart, it means that you have what's right here. You have what we call electrical capture on the bottom picture. Every time that you send electricity, you get a ventricular, or you get a QRS ventricular response. Okay. If you look at the picture one up, you don't have capture. The heart's still doing its own thing, and the pacer spikes are just chilling by themselves. The problem is that you can have electrical capture without mechanical capture. So after you put that patient on your transcutaneous pacing, you need to make sure that you also check for a mechanical pulse. Okay, you might feel the electric a little bit, but it's more like a muscle spasm on them, which is kind of just funky. But you will not get electrocuted, I promise. Definitely paced a guy once who, like, he just owed the entire way to the hospital, even though we sedated him. I did not realize that when you turn the pacing on, because you're doing it in the labs, you're doing it on a mannequin who doesn't complain. The second you hit pace, it turns it on. It doesn't matter if you have set what you want your pace to be, it turns it on immediately, and your patient will start going, ow, 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 immediately. So keep that in mind for when you do that, because you might want to make sure that you've given the patient appropriate sedation first. And I'll send you this video also, because there's always some idiot who is more than willing to pace himself or give himself a sternal IO. And that's it. Oh. Stop moving. I'm having a small technical. There we go. Hi, y'all. Thoughts, questions, concerns? Ashley, your son's going to do the next lecture, okay?
It's a girl.
Oh, I'm sorry, can't see. Your daughter's going to do the next lecture.
It's okay.
Wow.
Fail. Anyway, any thoughts or concerns about anything?
I got a random question.
Go ahead.
So my dad has a bundle branch block.
Okay.
And they told him that hopefully you never go into arrest because we can't shock you. Why? Can you not shock somebody who's got a bundle branch block?
Who said
like
that?
if they die?
Who told him?
His doctor.
You need a new doctor.
Right. Okay.
Just.
And he told, because he told me that, and I was like, that doesn't make sense. Why wouldn't Suffolk?
Like he's out east? Like how east?
No. Like we live in Selden, like right on exit 62. Okay. So we're literally,
Doctor, listen,
you work center, so you know where it is.
I'm going to give you your new cardiologist. I literally send every single, I have got my whole family, all my friends, Dr. Neil Patel. He's affiliated with Stony Brook. He's fantastic. Okay. Just
all right.
Go to him. Go to him, please, because
Mom goes to him.
I love him. I love Dr. Patel. I think that your dad's doctor's just a moron. Sorry.
Okay, fair enough. Thank you.
You're welcome. Any other questions? All right. Hold on, let me stop recording.